Microbiology, section 3. We will discuss the gram-positive rods and beaded filaments. And the gram-positive rods that we need to know are the Listeria, Corynebacterium, Clostridium, and Bacillus. And the beaded filaments bacteria are the Nocardiosis and Actinomycosis. So the four gram-positive rods, two of them are non-spore-forming, Listeria and Corynebacterium. The two spore-forming are the Clostridium, which is obligate anaerobe as well. So it's a spore-forming and obligate anaerobe. And we'll talk about the Bacillus as well. Listeria monocytogen. You guys remember when we talked about streptococcal pneumonia? I told you that if the patient has humoral immunity problem, he's going to get significant infection with the streptococcal pneumonia because it has the capsule and we require the immunoglobulin to opsonize the bacteria and overcome the bacteria. Here the situation is different. Look at this. Commonly seen in patients with diminished cellular immunity, not humoral. That's the Listeria because it's intracellular kind of parasite. So patients with AIDS, lymphoma, they have a problem in lymphocytes, leukemia. Look at this neonate. You guys remember when I told you, remember that the neonate might have a problem with Listeria. And the most common is B, Listeria, group B, E. coli, and Listeria. So that's something we need to remember. They might get meningitis in neonate with the Listeria. And for sure, patient with organ transplant or on corticosteroids for a long time, they will have what? Cell-mediated immunity, and they are going to be susceptible for the Listeria monocytogen infection. So look at this. Increased risk of listeriosis has not been associated with immunoglobulin or complement deficiency. Has not, only cell-mediated. Okay, how are you going to see the Listeria monocytogen? Contaminated milk and vegetables will go to the GI, and that will survive in the phagocytic cells, such as macrophage or neutrophil, and will spread through the nerves to the brain, and it can cause meningitis. You guys remember when we talked about the enterococcal infection? I told you don't touch cephalosporins. It's wrong answer. Again, enterococcal infection is resistant to cephalosporin, and Listeria is resistant to all cephalosporins as well. Okay? So ampicillin should be included in the treatment of meningitis in elderly or neonate because you suspect that they might have Listeria. Let me tell you about these things here. The Listeria monocytogen can survive. Actually, it is better grow and multiply in cold atmosphere, like temperature of 4 degrees centigrade. So they might ask you about this on the exam and tell you, a pregnant lady who is susceptible to get Listeria, what are you going to advise this lady? Avoid eating in deli or in the cold cut meat, because cold cut meat might have the infection and she might get the Listeria. So please remember this. They love to ask about it. So look at this. In a neonate, it could be infected transplacentally, and that can cause widespread fatal granuloma, or what we call it granulomatous infantiseptica. I'm sure that you know this term. The way that they ask you about this is they will tell you the patient has infection during early pregnancy, and then she has miscarriage. And look at this. Listen carefully. They will tell you the tissue of the miscarriage has a lot of granulomatous lesions. Once you see this, think of Listeria monocytogen. Miscarriage and the tissue of the miscarriage has granulomatous lesions, Listeria monocytogenes. If you or I have the infection, most probably it's going to be asymptomatic because we have good immunity. At least we think that we have cell-mediated immunity, good, working. If the diminished immunity in infants can cause meningitis, as we talked about it, pregnant women, spontaneous abortion, and the organisms could be isolated from the placental membrane. And Listeria, when grow in a temperature, low temperature on blood agar, it's a gram-positive rods, which will move with tumbling motion. So please remember the word tumbling motion in cold atmosphere, best in colder atmosphere, okay? That's why the pregnant ladies have to avoid eating the cold cut meat because they might get the infection. It is facultative intracellular parasite spread between cells through actin rockers or rockets. So this is what we call it, the tumbling motion. And the other bacteria that has tumbling motion is the Proteus mirabilis. So these are the two bacteria that might described as having tumbling motion. 75-year-old man who has received the 20 milligram per day of prednisone for vasculitis for the last 6 months, went to the ER with fever, chills, neck stiffness, has temperature of 38.5 centigrade, and meningismus. CSF shows leukocyte count of 2,600, 40% is polymorphonuclear, 60% lymphocyte and monocyte, and the glucose is low of 36 milligram per deciliter, and the gram stain was negative. Let me tell you, I don't mean gram-negative bacteria. I mean that the gram stain didn't show any bacteria, okay? While waiting final culture results, you recommend which of the following antimicrobial therapy? And why? Anyone will answer this question, he's going to tell me why. Let me tell you, that's easy. And expect this on the exam. This is a patient with meningitis. He's an old guy. So always think about it, the extreme of age, either neonate or old. And what is the other thing that I told you about it in the scenario? Look at this. When they give you a hint on the exam or give you something on the scenario, it is not for free. Either to exclude something or to include something. So this will include what? It means that this patient has humoral deficiency or cell-mediated immunity deficiency because he's on prednisone. Cell-mediated immunity deficiency. So please remember, being on corticosteroids will make your cell-mediated immunity suppressed. So we have two big factors here. This patient might be susceptible to which kind of microorganism in his brain? Listeria monocytogenes. Why? Because he's an old guy, because he has cell-mediated immunity deficiency. So what are you going to cover with it? I told you about this before. You have to add what? Excellent. So select the answer that has the ampicillin. Vancomycin and ceftriaxone has to be there. Why? Because who knows? It could be streptococcal pneumonia. So we have to cover this until you get the final diagnosis from the lab, maybe after a day or 2 or 3. So you have to continue the 3 antibiotics until you get the final diagnosis. And they tell you, hey, this patient has listeria. And in this situation, you can just continue ampicillin. Or if they tell you the patient doesn't have listeria, the patient has streptococcal pneumonia, what are you going to do? Forget about the ampicillin and continue vancomycin and ceftriaxone. So I'm trying to tell you the concept so you don't have to memorize, because the worst thing that you do for yourself in the pharmacology is to look at some tables. because that's going to confuse you on the exam, because they were not going to provide you with a table, they would provide you with a real scenario. The Corynebacterium is the other gram-positive rod. Could be Corynebacterium diphtheria, or the other one is Corynebacterium jejunum. And I'm going to tell you how to see this. That's very classic. I'm sure everyone here in the class knows how the Corynebacterium bacteria is presenting. It is upper respiratory infection with the gray-white pharyngeal pseudomembrane. They call it ball neck because it's going to be edematous from the inflammation. And there is hoarseness and soreness of the throat. And remember that the patient is going to be significantly sick and toxic, but they will not going to tell you that the temperature is 104 or something like that. They will tell you the temperature is 100.9, not very high temperature. So that's something on the Corynebacterium diphtheria. You guys remember I told you that this is one of the bacteria that will become more toxic with the lysogenic kind of activity when we talked about the gene transfer. And this is going to be the toxins produced by the Corynebacterium causing myocarditis and polyneuritis. And let me tell you about this trick, because this is very important to know for the exam. If they asked you, how do you treat the patient with Corynebacterium diphtheria? I'm talking about the patient who has the real disease. He's toxic right now, and he has the ball neck, and he has all the signs, low-grade fever, carditis, polyneuritis, all these things. They will give you the choices of different antibiotics. Even they will give you the erythromycin or the penicillin. Select the one that will have the antibiotic and the antitoxin. However, if they give you the choice of antibiotics and one choice with the antitoxin, select this one and forget about the antibiotics. Why? Because the patient is going to die from the toxic effect. The bacteria will not going to kill the patient at this stage. The patient is going to die from the toxins secreted by the bacteria. So block the toxins to save the life of the patient. Is this clear? And we have 3 diseases. I'm going to tell you that the right answer on the exam is going to be the antitoxin. One of them is the Corynebacterium diphtheria. So the answer for this question, always start the antibiotic early and keep antitoxin late. Is this true or false? This is false, false, false. Always start with the antitoxin, okay? What about the Corynebacterium jejunum or JK? How are you going to see this on the exam? If they want to ask you about it, it's going to be neutropenic patient, post-bone marrow transplant, and he started to have septicemia. What is the treatment? Vancomycin. What is the microorganism? Corynebacterium jejunum. So it's going to be very classic presentation. Patients is neutropenic. Why neutropenic? Because basically when we do the bone marrow transplant, we have to kill all the bone marrow cells. So the patient is going to be neutropenic anyway, and it's going to be susceptible to infection. And at this situation, Corynebacterium jejunum is the one that might affect this patient, and the treatment is vancomycin. So antibiotics are used only to prevent the transmission of infection. I'm talking about Corynebacterium diphtheria from patients or carrier. And it has no effect on healing of local infection of diphtheria patient, meaning patient already has the disease and he's toxic right now, give the antitoxin because the antibiotic is going to be useless at this stage. Corynebacterium diphtheria, microbiology for level 1, gram-positive, aerobic. I'm sure that you know this, Chinese letter appearance. That's very generic. We know this. Chinese letter appearance in patients with Corynebacterium diphtheria under microscopy. Black colonies on cysteine, tolurite, and basically the cytoplasm contain metachromatic granules that stain with aniline dyes. Here's the question, basically. We have to know this, no doubt about it. Diphtheria toxin will ADP ribosylate the host, which is our cells, elongation factor 2, and that will cause destruction or misfunction of the elongation factor 2, and that will inhibit the protein formation, and that will cause our cell death. That's how the toxin of the diphtheria will cause cell death. Why do you see this gray-white membrane on the pharynx of the patient? Because of the death of the cells. And that's basically what the bacteria is doing. So that's the toxins of the bacteria causing the, disabling the elongation factor 2, and that will cause protein synthesis inhibition and cell death. Here is something else that we need to know for the microbiology. Remember that Pseudomonas aeruginosa uses the virulence factor exotoxin A to do the same. ADP ribosylate the elongation factor 2 in the host cell exactly like the diphtheria toxin is doing. So if you, the question will be, they give you one scenario and they will ask you which other bacteria that causing its toxicity with the same mechanism, and they put list. And if they give you Corynebacterium diphtheria scenario, they will put different bacteria. One of them is Pseudomonas aeruginosa. If they tell you the patient has been diagnosed with sepsis with Pseudomonas aeruginosa and he's toxic, what is the other microorganism that will cause the toxin with the same mechanism? That's Corynebacterium diphtheria. Is this clear? So this is actually, this step is post-translation modification of protein by adding ADP ribose from the NAD. So here is the ADP ribosylating AB toxins, which is basically the addition of ADP ribose to a protein. Any protein, you can add this, and it's going to be disabling to the protein. So Corynebacterium diphtheria and Pseudomonas aeruginosa inhibiting elongation factor 2 in our body, inhibiting protein synthesis and causing cell death. And let me tell you about the other bacteria. We have the Vibrio cholera and E. coli enterotoxigenic will cause watery diarrhea, and Bordetella pertussis can cause whooping cough and lymphocytosis with the same mechanism, which is adding ADP ribose to a protein. I'm going to talk about this again. So the JK that we talked about it before, it could be IV catheter infection, but most important, bone marrow transplant, neutropenic patient, vancomycin is the drug of choice. Clostridium, we have Clostridium difficile. I'm going to talk about it in a little bit of detail. Clostridium botulinum, which can cause botulism, and it will block the presynaptic acetylcholine release. Usually the most common example that they give you on the exam is the baby who's feeding with honey. Why? Because basically canning the honey might be contaminated with this anaerobic bacteria, and it might induce or produce the toxin, and then the baby is eating this honey and having the toxin in it, and he's going to present with the botulism, which is like flabby baby. The Clostridium perfringens, you guys remember when we talked about necrotizing fasciitis in streptococcal infection before? I told you that this is bad infection in the deep fascia. It is the same, and it can be caused by multiple microorganisms, including the Clostridium perfringens. So this is the necrotizing fasciitis, and the problem with this kind of bacteria, Clostridium, has lysisinase and hyaluronidase, and can be demonstrated by culturing on egg yolk agar, And the other bacteria that could be involved in necrotizing fasciitis is Vibrio vulnificus, not Vibrio cholera. And Bacteroides fragilis is another bacteria causing necrotizing fasciitis. Look at this surgical consult for debridement. You have to be very aggressive in the debridement of this condition. Don't worry about this bare areas, because you can cover it with a flap or skin graft, whatever the situation. The other problem with the Clostridium perfringens is food poisoning, and this is one of the food poisoning that will respond to antibiotics, so give penicillin to these patients. Clostridium septicum, I think we talked about this when we talked about Streptococcus bovis. Everyone will remember this. Patient with sepsis or endocarditis with streptococcal infection bovis, streptococcal bovis, or Clostridium septicum, think of GI malignancy. We're not going to miss it. Sepsis or endocarditis caused by Clostridium septicum or Streptococcus bovis, think of GI. Sometimes they will not going to ask you about GI malignancy. They will tell you, what should you do to this patient? Select colonoscopy, because we want to see if the patient has malignancy or not. Then the Clostridium tetani can cause the tetanus. All of the following statements about Clostridium difficile colitis are true except one. Who's going to tell me the wrong one? Let us go through this one by one. Colitis due to C. difficile can occur 2 to 4 weeks after stopping the treatment of offending antibiotic. Is this true or false? It is true. It doesn't have to be after a day or two or during the antibiotic administration. It could be after 2 or 3 weeks. Appropriate treatment for this patient should be 500 milligram orally, metronidazole 3 times a day. That's the right answer. Relapse after treatment of C. difficile colitis is frequent. Yes, you will see this a lot. This is the wrong answer, because we want to keep vancomycin for the serious kind of infections, and since we have the metronidazole is working. But toxic megacolon can be a complication of C. difficile colitis. And what do you mean by toxic megacolon? The patient will have significant paralysis of the colon. And we have seen, in fact, a few weeks ago, we admitted patient and he has the diameter of the colon was 9 centimeters. So it was significantly dilated, and he has toxic megacolon. Okay, so the C. difficile colitis, it's a spore forming, and they secrete 2 polypeptide toxins. We have toxin A and B. Toxin A will increase fluid secretion. That's the cause of diarrhea and hypoalbuminemia. Toxin B is cytotoxic to the mucosal cells. That's why it's going to cause what we call it pseudomembrane, which is just the necrotic tissue sticking to the superficial layer of the mucosa, giving the appearance of membrane, but it is pseudomembrane. How do you diagnose this? Never, look at this, not by stool culture, never. They will try to trick you and say, send the patient for stool culture. No, we need to know if the patient has the toxins in the stool or not. Why? Because this bacteria is seen in normal person like you and me. We might have it, but it's not active. If it is active and infectious, it's going to secrete the toxins A and B. So how do you diagnose C. difficile colitis? Never select culture. It is check for toxin A and B. The treatment, the first line of treatment is metronidazole, or if they tell you the patient has resistance or basically recurrent infection, you might select vancomycin, but never IV. They will try to trick you and tell you the patient is sick, give him IV. Vancomycin, never select. It will not going to work. It should be oral vancomycin. And anyway, we need to try to avoid vancomycin. It's not the first drug of choice. And for sure, you have to discontinue the offending antibiotic. And look at this. They might give you easy scenario of C. difficile colitis. And they will forget about everything in microbiology that we talked about it. And they will ask you about this. How are you going to sterilize the bedpan of the patient? Okay? So remember, exposure to saturated steam, at least 121 degree for 15 minutes is required for sterilization of bedpan. So please remember this, it could be the question. 4 months old infant presents with failure to thrive, progressive muscular weakness, and poor head control. On questioning, the mother states that she typically feeds the baby soy-based formula sweetened with honey. Which of the following organism is most likely responsible for the child? We know this. Which one? Clostridium? Yep, that's right. That's the botulinum. So the botulinum can cause what we call it floppy baby syndrome, which is due to toxins, which is found in the honey, and it's going to go to the baby's GI tract, and it's anaerobic spore-forming oval subterminal endospores found in the soil. Let me ask you about this question here. IV antibiotic is the first measure for the treatment of a patient with botulism. Is this true or false? False. That's good to hear. So we talked about another infection that you treat with the antitoxin, which was Clostridium, which was Corynebacterium diphtheria. And now we have Clostridium botulinum. And this is false. Why? Look at this. Botulinum toxins type A to G are released to the environment after bacterial autolysis. So the illness is caused by ingestion of food contaminated with the toxin that will block presynaptic acetylcholine release, causing the flaccid paralysis. So the use of antibiotics would be useless since there is no living bacteria, and the treatment is antitoxin. So they will try to push you to select antibiotic. No antibiotic. This is antitoxin. So that's the second one that we will select, the antitoxin. Clostridium perfringens can cause food poisoning. I told you that this is one of the food poisoning that could be treated with penicillin. Again, necrotizing fasciitis is involving the Clostridium perfringens. And look at this. I want to remind you with the Vibrio vulnificus, Bacteroid fragilis can cause necrotizing fasciitis, and consult surgery plus vanco, penicillin, Clenda. So when they give you choices, look at the choice that has the Clenda in it. Once you have this, select this one. That would be the right answer for the necrotizing fasciitis. Clostridium tetani can cause the tetanus. I think we described this before, if you remember, when we talked about the spores. And it's a drumstick or tennis rackets. And it is gram-positive bacilli, a drumstick appearance found in the intestine of man and animal and parasites, and produces potent biological toxin, which is tetanospasmin. Look at this. The example that you might see is called neonatal tetanus, and it's due to contamination of the cut umbilical cord after birth. We don't see this here in the United States, but it can be seen in developing countries when the instruments are not very sterilized. So immunize the mother. That will protect her infant by passing immunoglobulin G to the fetus until he has his immunization when he's 2 months old. I want to remind you with this, immunoglobulin G is the only immunoglobulin that can pass through the placenta, and basically it's going to give immunization to the fetus in the first 2 months before he's getting the immunization. Tetanospasmin toxin blocks the release of inhibitory neurotransmitters, particularly the GABA and the glycine, from the Renshaw cells. And these are inhibitory interneuron found in the gray matter of the spinal cord. That's why when you inhibit the inhibitory, you will get the spastic problem.